Hi, I'm Phil Siegel, and I'm an endocrinologist at Toronto General and Mount Sinai Hospital. In this, in this video, I hope to provide an overview of some of the practical aspects of starting, monitoring, and adjusting insulin. I have received honoraria from the Canadian Council of Pharmaceutical Education, from Medtronic, and from Novo Nordisk. Novo Nordisk makes a brand of insulin, and images from the CCPE do appear in this presentation. However, I was involved in the design and editing of all of the relevant CCP images, and we will be discussing classes of insulin and not specific brands in isolation. By the end of this video, I hope you'll be able to understand the properties of commonly prescribed insulin regimens, and that you'll gain proficiency initiating and adjusting insulin in patients with diabetes. Remember, insulin is involved in energy storage. It promotes the uptake of glucose into the cell and the storage of glucose in the form of glycogen. It also prevents fat breakdown and promotes protein synthesis. Without insulin, hyperglycemia results and fat is broken down and leaches into the circulation and are eventually converted into ketone bodies. Ever since the discovery and purification of insulin in the 1920s, we've been using it to treat our patients with diabetes. Every patient with type 1 diabetes needs insulin. Many of our patients with type 2 diabetes also need insulin, particularly at later stages of the disease. Some of our patients with gestational diabetes will eventually require insulin. So here's what's good about insulin. It's very good at lowering hemoglobin A1C. You'll learn about hemoglobin A1C later in the module, but it is a marker of our patient's overall glycemic control during the past 3 months. We can easily titrate the dose of insulin, one day giving more or less units as compared to the next. It can be used in any type of diabetes, type 1, type 2, gestational, and so on. And we can tailor various insulin regimens to our patient's lifestyle and diet. If a patient, for example, misses his or her meal, then he or she wouldn't take their insulin injection at that time. It's also safe to use in pregnancy. Here's what's bad about insulin. It can cause hypoglycemia, and hypoglycemia can be very serious, thus necessitating monitoring of capillary blood sugars, and our patients often need to prick their fingers up to 4 times a day or more. It causes weight gain because insulin is an anabolic hormone. It's an injection, it's not a pill, and many of our patients are not keen to take injections. And the prescriber needs some competency initiating and adjusting insulin. It takes a little bit of finesse to prescribe insulin, but I hope to show you how in the next few slides. Now this slide is very important and illustrates normal physiology. On the y-axis is plasma insulin concentration, and the x-axis shows the various times throughout the day. You'll notice 2 things. The first is that overnight, serum insulin concentrations are never 0. There's always an ambient concentration of insulin. This is called basal insulin. Basal insulin is required to prevent the liver in particular from synthesizing and secreting glucose during times of fasting, such as when we're sleeping. Also notice these 3 peaks. This is the insulin that the pancreas secretes in order to dispose of glucose from each meal, and this is referred to as bolus insulin. So when we're prescribing insulin for our patients, we want to match physiology with pharmacology as much as possible. That's why we have to think about prescribing some form of basal insulin, something for bolus, which is also referred to as prandial requirements, and we also have to think about prescribing extra insulin for times of hyperglycemia, which is called a correction factor. There are many different commercial insulin preparations available, some with basal and others with bolus-like properties. Basal insulins are injected and have a very slow onset of action and last for quite a long time. On the right, you'll see one of the long-acting insulin brands called Glargine, which lasts for 24 hours. Bolus insulins are quite short-acting and have a very rapid peak and are best used shortly before each meal. What makes one insulin preparation different from another is modifications to the insulin molecule, which changes its absorption properties from the subcutaneous tissues to the bloodstream once injected under the skin. Here's an example of glargine insulin, which is a basal or long-acting insulin, where 2 arginine molecules have been added to the end. This modification delays absorption of glargine from the subcutaneous tissues once it's injected and produces a long, sustained, and fairly flat effect over the course of 24 hours. This is why this type of insulin is classified as a basal insulin. This table was taken from the Canadian Diabetes Association and will be made available to you on the portal. It shows the currently available basal and bolus preparations that we use in practice. You'll see that the bolus insulins have a rapid onset, usually 10 to 15 minutes. They usually peak within 1 to 1.5 hours, and they are gone after 5 hours. Whereas some of the common basal insulins don't start working for 90 minutes, but can last up to 24 hours. Insulin is a protein, so it can't be administered orally, but it has to be injected under the skin. Most of our patients do this with an insulin pen attached to a 4 to 8 millimeter needle. It can be injected into multiple sites on the body, but the most important thing is that our patients rotate each injection. This is someone who is injecting insulin into the same 2 places every time. And over the course of months to years, the tissue can become quite firm, leading to something called lipohypertrophy. Now, there are 3 commonly prescribed insulin regimens. The first is a basal insulin only. The second uses some pre-mixed insulin preparations, which I'll go into in the subsequent slides. And the third is termed multiple daily injections, or an MDI regimen. Now, they all start at the same place, and that's by estimating a patient's total daily insulin requirement. There are many ways to do this, but one simple way is to use this formula, 0.5 units per kilogram. So if you're seeing an 80 kilogram man who you need to start insulin, we would start around 40 units per day. This is just a starting point, and the dose will need to be adjusted subsequently. The next step is to allocate basal and bolus insulin. A simple rule is that 50% of one's total daily requirements are for basal needs and 50% for bolus needs. In this case, 20 units of the total dose should be given as a basal preparation and 20 units as a bolus. The next step is to decide on the best regimen for the patient in front of you. Some patients can only want to take 1 injection of insulin a day, or only need 1 injection of insulin a day, and in that case we would simply give the basal injection, such as glargine, 20 units before bed. Or in the case of NPH insulin, which is another type of basal insulin, we would give it as 10 units twice a day. This is an excellent insulin regimen, but it doesn't provide any prandial insulin for meals. An MDI insulin regimen provides both bolus and prandial insulin. Almost all of our patients with type 1 diabetes are using an MDI insulin regimen. But it still starts with the estimation of one's total daily dose, in this case 40 units per day. That dose is divided 50% basal and 50% bolus, and then proportioned according to this. In this case, 20 units are given as glargine, and 7 units with breakfast, 7 units with lunch, and 7 units with dinner. This is the shorthand you'll see at the bottom of your screen, which is approximately 20 units. This is what an MDI insulin regimen looks like. Often it requires 4 injections or more of insulin a day. one injection in the evening, in this case for 20 units of glargine, and an injection of insulin each time with each meal. If someone has a high blood sugar before a meal, they'll need to take extra bolus insulin in addition to the prescribed amount in order to correct for this. This is called the correction factor, which is defined as the additional rapid insulin one requires at meals to correct for hyperglycemia. Correction factor can be estimated by the formula 90 over the total daily dose of insulin. So for example, someone who takes 30 units of insulin per day total would have an estimated correction factor of 3. And this means that for every extra unit of insulin administered, he or she can expect their blood sugar to fall by about 3 millimoles per liter. So let's do an example to illustrate the correction factor. Here's a gentleman who takes 15 units of glargine insulin at night to meet his basal requirements, and 5 units of bolus Lispro prior to each meal for his prandial requirement. Let's say he calls you at your office and says, my blood sugar is 16. Do I take 5 units or more? And I'll tell you that we generally like our patient's blood sugar to be between 4 and 7 millimoles per liter before each meal. So to answer this, we need to calculate the correction factor. In this case, his correction factor comes out to 3, which means that for every 1 extra unit of insulin he takes, we can anticipate his blood sugar will fall by 3 millimoles per liter. So he still needs to take his scheduled 5 units of Lispro because he's about to eat a meal, but he needs to take extra insulin to account for the fact that his blood sugar is high at the beginning of the meal. In this case, the extra insulin comes out to 3 units, and so he needs to take a total of 8 units of Lispro before his lunch. We can also use insulin mixtures that contain fixed ratios of both basal and bolus insulin. The most common is called insulin 30-70. The 70 refers to 70% basal per injection, in this case NPH. 30 refers to 30% bolus insulin. So for each unit of insulin administered, 30% of it will be bolus and 70% will be basal NPH insulin. The benefit of using premixed insulin is that it only needs to be injected twice a day. So many of our patients who don't want to take more injections yet can't achieve good blood sugar control with a single basal insulin administration may like a premixed insulin regimen. Premixed insulins are given before breakfast and before dinner. Prescribing a premixed insulin starts the very same way, with an estimation of total daily dose. For an 80 kilogram man with requiring approximately 0.5 units per kilogram, he'll require 40 units per day. It's proportioned a little bit differently at the outset. 2/3 of it is given in the morning and 1/3 pre-supper. So in this case, we would start with 25 units of 30-70 insulin in the morning and 15 units of 37 insulin before dinner. One of my teachers once told me that it doesn't matter what dose of insulin you prescribe because it's always going to be wrong at the outset. What's more important is that you prescribe insulin according to the basic principles of basal and bolus. But most of our patients will need to adjust their dose of insulin subsequent to this. And there are some very important principles to adjusting insulin. The most important is that you must think about the type of insulin that is acting at the time of the high blood sugar. So for example, if the blood sugar is high first thing in the morning, and this is called fasting insulin, then the only insulin that's acting at that time is the basal insulin taken the night before, and that's the insulin that needs to be increased. If the blood sugar is high at lunch, then people need to increase the insulin they took before their breakfast, because that's the insulin that's acting right before lunch. If the blood sugar is high before supper, the insulin before lunch needs to be increased, or if they're taking some basal insulin before breakfast, that can also be increased. And finally, if the blood sugar is high before bed, then it's the supper time insulin that needs to be increased. Here's another example that I hope will clarify things. So, Someone has a high blood sugar at breakfast of 12.4. We generally like our fasting blood sugar to be between 4 and 7. So if the fasting blood sugar is high, then the solution to this is to increase the bedtime insulin the next day. Here's another example where the supper time insulin is high. The solution to this is to increase the basal insulin that was taken before breakfast, or to increase the rapid insulin taken before lunch, so that patients don't arrive at supper with a high blood sugar. So let's do an example of a 100 kilogram woman with type 2 diabetes who has a hemoglobin A1C of 9.1%, which is quite poor and likely means that she has severe hyperglycemia. We want to start insulin. So the first step is to estimate the total daily dose, in this case 50 units. Then to proportion 50% basal and 50% bolus, and finally to decide upon the best regimen for the patient in front of you. Now she only wants to, or is only willing to take 1 injection of insulin per day, and so we will administer this as a basal dose of glargine before bed, 25 units. 3 months later she comes back and her hemoglobin A1C has fallen to 8.3%, and I'll tell you that we generally like A1C to be 7% or less. So 8.3% is good, but it could be better. And so we ask her to start checking her blood sugars before lunch, before supper, and before bed. A little bit later, she comes back and shows you this table, which is the average blood sugar at each time point. So you can see that the fasting blood sugar is 7, which is quite good, but the lunch, supper, and evening blood sugars are higher than we would like. And so 4 units of aspart insulin are added before each meal. 1 month later, she comes back, and her bedtime insulin, her average bedtime insulin, is actually quite good, but the lunch and supper time are still high. So because the lunch is high, we need to increase the insulin at breakfast. And because the supper time is high, we need to increase the insulin at lunch. But the evening blood sugar is quite good, and so she stays on the 4 units of aspart. This is how we adjust and titrate insulin based on capillary blood sugar values. Let's do one final scenario of a 100 kilogram man with type 2 diabetes who has a hemoglobin A1C of 9.1% and needs insulin. We estimate his total daily dose to be 50 units a day, but he decides to take an insulin mixture 30/70, which, as we discussed previously, is prescribed a little bit differently at the outset, proportioned 2/3 in the morning and 1/3 in the evening. So this is our shorthand of our prescription of 30/70 insulin, 33 units before breakfast, 0 units before lunch, 18 units before dinner, and no units before bed. He comes back a little while later, and he's checking his sugars twice a day before breakfast and before supper. You can see that the fasting blood sugar of 7 is quite good, but his average dinner time insulin is still high. So what change needs to be made? The answer is that the insulin acting before supper is actually from the morning injection. So this injection, or this dose, needs to be increased. And so we make an adjustment and ask him to take 36 units before breakfast so that he can arrive at dinner with a normal blood sugar. So, using insulin is easy, as long as you understand the difference between basal and bolus, and understand the 3 most commonly used insulin strategies: basal only, premixed insulin injections, and multiple daily injections. As long as you can understand how to estimate the total daily dose, and realize that patients will inevitably need to adjust their insulin, and understand how to make small adjustments to reach target. So by now, I hope that you're able to understand the properties of commonly prescribed insulin regimens. I hope that you've gained proficiency initiating and adjusting insulin in patients with your diabetes.